Good afternoon, I'm Michael Bailey. I'm one of the physician assistants with HealthWorks Medical, and today I'm going to be speaking on cardiovascular disease and its prevalence, particularly with the state of Kentucky. But the subtitle of this is Fried, Fat, and Fooled, and I'm going to kind of walk you through why I decided to present it this way. First of all, just ask the obvious questions of what is cardiovascular disease and why is it that you and I should care about this beyond me just practicing medicine. Taking a look at Kentucky specifically by itself here, I want to show you some comparisons between both nationwide statistics and Kentucky itself. If you look at the graph here, on the left you'll see the gray colored portion of the bar graph, and this walks us through several different risk factors for cardiovascular disease and stroke. And it goes from everything from diabetes to smoking, high blood pressure, high cholesterol. But you can just see graphically how much Kentucky extends ahead of the national norms beyond these risk factors. And this is just a graphical representation of some of the overall poor health status that we have in the state of Kentucky. Consistently, Kentucky ranks among the top 10 as far as death rates from cardiovascular disease. This is from statistics, I think, dating back to 2010. And in 2010, 23% of deaths in the state of Kentucky were attributable to cardiovascular disease. A couple more encouraging statistics about the state. This is between a range of 2005 and 2007, according to the Centers for Disease Control, and also from some of Kentucky's health initiatives looking at cardiovascular disease prevention and stroke prevention. A couple things that I want to point out to you on this slide here is especially the rate of tobacco use. If you come down 4 lines here, 28% of people as adults in the state of Kentucky were identified themselves as tobacco users. But the one that bothered me the most was 26% of high school students identified themselves as users of tobacco as well. Additionally to this, approximately 85% of total adults and adolescents were overweight or obese, and then only about 69% of high school students received any sort of physical education at all. So a couple of these risk factors, taking a look at them individually and how they increase your risk for cardiovascular disease. Tobacco use itself makes you have about a 4 times increased risk of a cardiovascular event, and that's either fatal or non-fatal heart attack and or stroke than opposed to those that do not use tobacco. Nicotine itself causes vasoconstriction, blood vessels clamp down, and this increases your heart rate. Also tries in an effort to increase your cardiac output, which is kind of the pumping power and output of the heart, and over time this leads to some damage of the heart muscle cells themselves, but also the vascular cells that line all your blood vessels from head to toe. How does obesity increase your risk? This says that obesity can be linked to a virus, and the lady on the left is obviously pregnant, and the guy on the right says that he's eating for 2, eating for him and his virus. Love it. I think I probably have a virus. But obesity does several things to your heart over time, and one of the things that it does is just overall increases the workload of the heart. So if you think about this from head to toe in your body, just to perfuse the extra pounds that you have, say on your gut, that's a lot of increased vascularity, or a much larger network that your heart has to pump against than if you didn't have those extra pounds on your gut. And so what that does over time is the heart's just like any other muscle. The more you work it, the bigger it gets. And so over time what this will do is decreases the efficiency of the heart. In terms of exercise and what its protective benefits are, is that it reduces your risk of other comorbidities that increase your cardiovascular risk. And that those are things such as diabetes. It also helps improve your lipids and the ratio between these. But also over time it requires that the heart requires less oxygen demand because the output of the heart increases with this. And the other thing that I like about exercise from a clinical standpoint is that it gives me an idea of what a person is capable of, so that way if there is a change in time, you can perceive that a little bit more readily than, say, you're a couch potato every day that doesn't do a whole lot, and you start having cardiovascular symptoms. To look at cholesterol as a risk itself, just to kind of educate you a little bit about cholesterol and lipids. Cholesterol is manufactured through your liver cells, and so through a complex process of your digestion and absorption, your body packages cholesterol for several different purposes. What we do nowadays, though, is look at the specific types of cholesterols that are floating around in your bloodstream. And a couple of the most important are triglycerides. And what triglycerides do, triglycerides are usually at the center of all of our lipid molecules, and these hop up very readily depending on the kind of foods that we're putting in our mouth. And so if we have a lot of fried and fatty processed foods, the triglycerides tend to go up pretty readily. In the general population, less than 150 is considered a normal triglyceride level. Anything above 150 really starts to concern me. And a lot of our patients, will hang up in the 200 to 400 range, but many people, because of genetic problems as well, will have triglycerides levels that will climb well into the thousands. Another lipid that we pay attention to is the LDL, and this is the quote-unquote bad cholesterol. And the reason we call this the bad cholesterol is because we know that LDL likes to squeeze in between all the little cells that line your blood vessels and get into the wall of the artery. And arteries are the blood vessels that take blood away or carry blood away from the heart, whereas veins are carrying it back to the heart. And the structure between arteries and veins is completely different. Arteries have a little bit of muscle associated with it. And arteries, because they're responsible for the delivery of oxygenated blood to our cells and all the nutrients, are of primary concern, and LDL likes to squeeze in between the cells and infiltrate that cell wall or that vessel wall. And so this graphic here just demonstrates that. Again, kind of referencing normal ranges, I aim for most of my patients to have an optimal LDL level of 70 or less. Without other comorbidities such as diabetes, smoking, obesity, high blood pressure, 100 may be acceptable, but if you look chronologically at studies that are out there on vascular disease, it's much more preferable to have less and less LDL. So to me it reasons to have all my patients try and aim for a goal of 70 or less because the likelihood of you plugging up arteries is going to be less, and I'll explain that a little bit more in a couple more slides. The final lipid that I'll go over with you really quickly is HDL cholesterol, and this is the quote-unquote good cholesterol. And part of that is because what we know HDL, or high-density lipoprotein, does is it's a high density, it's a little bit more compact molecule, and what it does is it kind of packages up some of the bad cholesterols and helps you export it out of the cell wall, out of the vessel wall, and out of the circulation. And so that makes you less prone to forming plaque within the arteries. Acceptable levels of this are virtually the higher the better, especially if you're a male. I'm going to really try and press this, but a lot of people, both because of our lifestyles, our eating habits, and genetics, tend to have lower HDL levels. We know that the higher this goes, the more heart protective they are, but also if you have very low levels, that by itself is sort of an independent risk factor, just like it would be if you had a very high LDL or bad cholesterol level. This is just a graphic of what a normal artery wall appears like. There's kind of three parts that we pay attention to. The intima, which is intimate, it's in the inside. This is the immediate lining within the circulation. Then the media, which obviously is in the middle between the two, and then the adventitia, which is the exterior portion of the vessel wall. And what happens here is I'll show you the lipids that float around in our bloodstream start to infiltrate this vessel wall, and it does it through the intima, and then a lot of the disease process occurs within the media. And so we look at the media of different artery walls as a measure of disease progression of cardiovascular disease. And so a blowing up picture of this looks kind of like this does down here, with the lipid molecule and the LDL starting to infiltrate through the vessel wall. What happens over time is that as this comes in, this creates inflammation. And we know that lipids and cholesterols, when they're kind of out of whack in your circulation and in your body, create an inflammatory process. And so just like getting a splinter in your finger, and that creates inflammation, and your immune system reacts to that, your immune system also reacts to this. And so over time, your immune system places a bunch of white blood cells here to try and help clean up the junk and the damage that's occurring in the vessel wall. And one blood cell that does that in particular is one called macrophages. And as these macrophages gobble up the cholesterol and try to process this and clean things up, they tend to become overwhelmed, and they turn or transition into something called foam cells, which then help you form the plaque within the artery wall itself. And so I really try to think and teach my patients also of vascular disease and plaque in the arteries as an inflammatory process, just like arthritis is in your joints. And so over time you get an accumulation of these foam cells, which then grow in size. And that's what happens within the vessel wall here, is that you start out with this deposition of fat and all these white blood cells within the vessel wall, and we refer to that when it's very mild as a fatty streak. The interesting thing is that you don't have to be an old fart, you don't have to have high cholesterol, and you don't have to have all these other risk factors to develop fatty streaks. In fact, we know from post-mortem data that you can start developing fatty streaks as early as just a couple years of age. And we can look at 6-year-olds and 7-year-olds and their coronary arteries in their heart and see that there's fatty streaks already being deposited within the vessel wall. Over time, if this process is allowed to continue, you develop plaque, which is now measurable in that it's starting to change the caliber of the blood vessels. And in particular, we're referring to coronary arteries in this instance. As this continues and the plaque grows, the surface of that plaque thins out. And so that intima, that lining on the inside of the blood vessel walls, becomes very thin and very friable, very fragile. And what can happen at times, because of other risk factors such as your diabetes, smoking, hypertension, is that plaque then will rupture. And so just like getting a splinter in your finger and exposing that splinter to your immune system, the same thing happens here. This plaque then ruptures and it exposes it to your immune system and your circulation, and that draws in a huge inflammatory response. Part of that occurring is your body trying to stabilize what's going on. And so it puts a little package of platelets and other clotting factors right over that to try and seal it up, try to put a Band-Aid over that. But as this continues to develop, one of the risks is if the circulation is narrow enough and the blood flow is slow enough because of this plaque, is that you'll not only do that, but you'll continue to add other parts of your immune system that clot that and eventually close that completely off. And that's what happens here in the case of somebody that would have a heart attack. And so it'll look similar to this in a cross-section. What it does then is it ends up starving all the heart muscle that is perfused downstream from the point of that blockage. And so that's how people end up with a heart attack. So some symptoms of coronary artery disease and symptoms of this progressing include the following. It can start out just as fatigue or feeling tired, feeling as though you have less stamina. And this is for Lourdes. I better change the picture for Baptist. We'll put Lourdes up there instead. From decreased stamina to shortness of breath, to feeling more tired than usual, to shortness of breath, to chest tightness, then to chest pain. And that's all because of the progression that I just showed you. As these vessels start to become more and more narrowed, the muscle downstream tends to become more and more starved of oxygen. And certainly exertion and things like that then will demand more. So that's why you become progressively symptomatic and can't ignore some of these signs and symptoms. Again, going back to some of the risk factors that we talked about at the very beginning, include age, blood pressure, certainly your gender plays a role, and then tobacco use and some of the other things that we mentioned here. We need to talk about what to do about these things. At the bottom of this slide here, and for those that will be watching this online, if you go to www.heart.org, this is the American Heart Association's website, and there's a risk calculator that you can actually go to and sort of plug in your own individual numbers on this. But it'll take parameters such as smoking, high blood pressure, your age, and so on, and calculate your 10-year calculated risk of having a cardiovascular event over this. This map on the left graphically displays the incidence of cardiovascular deaths per 100,000 people. And so it's important to kind of keep in mind, because some of these areas that are highlighted are population less dense areas. But if you look at the state of Kentucky, you can see out in sort of the southeastern part of the state, we have a very high incidence of cardiovascular deaths. In fact, you can't get any higher on this particular map than the very dark red, and that's how our state's mostly colored. And we have a touch of that also in the western end of the state, northwest Tennessee, and kind of this sort of quad state area over here. But this darker area translates to somewhere between 500 and 1,200 deaths per 100,000 people, and this is just from fatal heart attack. That's a pretty high incidence, and you can see how, if I go back to that really quick, you can see how that's really predominantly clustered in the southeast United States. So when I said on the title, fat, fried, and fooled, or fried, fat, and fooled, what I mean by fooled is some of the things that patients tend to give me as excuses or justifications of not managing things as well as they should. And I hear these quotes all the time, such as, I eat salads a lot. But the problem is a lot of the salads they have bacon dressing and other really healthy things on top, tons of cheese and croutons. I only drink diet drinks, yet they're eating humongous portions of foods when they do it. I don't smoke, but they don't exercise, and they're a couple 100 pounds overweight. I work hard all day long, and a lot of patients and a lot of you that'll be, listening to this lecture online, work really hard, but that doesn't equate into cardiovascular exercise, and thus it doesn't calculate into risk reduction. And I argue with patients all the time because I work hard all day long, but I don't like to exercise, and so that's really not heart protective for me. And then I get people telling me they use Splenda, their fasting sugars in the morning when they don't eat anything are always low. Well, that's great because they're not eating anything, but then they run higher or more rampant with their sugars all day long. So there's a lot of excuses that we tend to make for ourselves because we don't find it as easy to manage these things, both with ourselves and with our healthcare providers. So let's give you an example of this, and I'm just going to give you what I would refer to as an average guy whose blood pressure might be elevated, 155/99, but the triglycerides can be really high, HDL, the quote-unquote good cholesterol is low, already taking some blood pressure medicines, has a bad family history, maybe overweight, and this is just a hypothetical kind of average guy here. Whereas, and I encounter this in the clinical setting all the time, is somebody who on the outside to me doesn't look all that healthy, but has really good numbers on paper. And the frustrating thing is that you can't sort of judge the book by its cover in this instance. There's plenty of people that walk around and even exercise or look skinny or don't eat huge portions, but may be really dyslipidemic or may have some really rampant high blood pressure. And then on the converse, we may have somebody who looks unhealthy, but overall has pretty low cardiovascular risks. And so this is why we need to be involved with our healthcare providers, and this is why we need to do blood work pretty regularly, and this is why we need to monitor these things, because we can control a lot of this. We can do a lot of it on our own, and then also medically as well. So that reasons us to ask, what are some things that we can do to reduce our risks overall? We can stop doing this. Long John Silver's, Western Kentucky barbecue, and the All-American fried chicken. And instead, we can start doing some of this, replacing it with some natural stuff that hasn't been cooked or processed, some things that actually grow. These things actually can almost eliminate a lot of the heart disease that we have. And I'm sure, Trish, you'll probably vouch for some of this as a dietitian too. I can virtually make your LDL go away if you're with a more plant-based diet. If you get rid of some of these animal proteins and some of the bad habits that we have, we can virtually eliminate a lot of the heart disease that you have. Some other things that we can do to reduce our risk as well is to participate in some of these programs that we have now offered for you guys through your employers, such as the Cooper-Clayton Smoking Cessation Method, regular meetings with your healthcare provider, and also getting on the treadmill. It doesn't help to just buy a treadmill and put it in the corner of the basement, but actually getting on it. Some other resources for you. I've just included a couple of websites here, starting with our HealthWorks medical website, where we post some of this information for you at your access, but also American Heart Association, the Cooper-Clayton Smoking Cessation, and then also Kentucky Heart Disease and Stroke Prevention Consortium, and then also our HealthWorks website. So just wanted to thank you for your time, and appreciate you listening to it.